Hi, I'm Jill Foose, and welcome to Afterpause. This podcast is for the woman who has made it through menopause and is ready to own what comes next. The woman who refuses to disappear, who still wants optimal health, energy, strength, power, great sex, confidence, style, beautiful hair and skin, and the next 20 to 30 years of her life to actually feel like living and knows she deserves every bit of it. This is Afterpause, and it's just getting good. Every episode is a real conversation built around one goal, telling you exactly what to do next. No guesswork, no noise, just clarity, direction, and action. Let's get into it. Hi, everyone, and welcome back to Afterpause, the podcast where you will find out what to do next in your menopause journey. No fluff, just precision, expertise, clarity, and direction. And today we are talking about plastic surgery. And there's so much noise on social media, in friend groups, at medi-spas about what actually works, both invasive and non-invasive. And I searched for the right expert to cut through it all. And one name kept coming up from every clinician that I trust: Dr. Lara Devgan. She has over 1 million Instagram followers. She was named New York's #1 female cosmetic surgeon by Rate MDs, featured in the New York Times, Vogue, Forbes, and the Wall Street Journal. But what sets her apart isn't her credentials, and we've barely touched on them. It's that she will look you in the eye and tell you what you actually need and what you don't need. She is trained as a classical artist before she even stepped into the world of medicine. She went to Yale, Johns Hopkins Medical School, Columbia, and New York Presbyterian for residency and fellowship. She operates on the principle that beauty is in the details, and we are talking millimeter level changes, not transformation, just enhancement. Her most fulfilled patients aren't the ones who look younger. They're the ones who look like themselves, well-rested, radiant, and congruent with how they feel inside. Beyond her practice, Dr. Devgan sits on the Lancet editorial board, the Vogue Beauty Board, and the Elle Advisory Board, and she has published over 100 peer-reviewed papers and is the founder of Dr. Devgan Scientific Beauty, a medical-grade skincare line built on the principle that efficacy is the new luxury. Her work sits at the intersection of surgical excellence, evidence-based science, and women's well-being. She is exactly who you need to hear from. So let's sit back, open your mind, and let's dive in with Dr. Devgan. Hi, Dr. Devgan. Welcome to Afterpause.
Thank you so much. I'm so thrilled to join.
I'm so happy to have you here today because, as you know, there's a lot of misinformation on the internet, and social media has a way of amplifying these procedures and treatments for women that may actually do more harm than good. And women want to just look like themselves. They want to be that fresh, vibrant version of themselves, which you do so well. But they also want to know what works and what doesn't work.
Absolutely. There is so much misinformation out there. And I think 10 years ago, we had the problem of not enough information. And today we have the problem of too much information, and there's a selection issue. So I'm so happy to help.
You have a philosophy called global facial optimization, which I find really interesting. But I'd like you to share with the community here, what does that mean and how is that different from how most plastic surgeons approach a face?
Plastic surgery has historically been about fixing little problems. There's a wrinkle, let's smooth it. Here's a bump, let's straighten it. There's a jowl, let's take it away. But when we think about facial attractiveness more holistically, what we're really looking at is balance between features, proportion, light and shadows, and overall harmony. So the idea of my concept of global facial optimization is that facial aging and facial changes happen all over in tiny little ways. And the way to best and most beautifully restore both youth and beauty to the female face or the male face is by thinking of how all of these areas can be slightly adjusted in identity-preserving ways to keep the balance of the face the same.
So you've also said that there's an era of how much we can do, which you said is pretty much over. And now we're in this era of what is the best we can do. And when do you think that shift happened in your practice and what drove it?
I think we're very much in the undetectable era where people don't want to lead with their work being done to their faces and bodies. They want to lead with themselves. And this
Mm.
idea of preserving identity while optimizing attractiveness is the underlying basis for that change in trend, but also that change in my own philosophy as a plastic and reconstructive surgeon. Historically, we thought about fixing one flaw at a time, but the best way to think about preserving facial attractiveness or optimizing it is to think about how can we tolerate minor imperfections in the interest of global facial attractiveness? So how
Mm.
can we keep you looking like yourself, but a more beautiful, more fresh version of yourself, rather than changing some of the important key identifying features of the face?
So when I think about that, I think about some women who've had just too much work, and it's clearly obvious, right? They don't look like they don't have a natural appearance in their face. Why is it that some plastic surgeons go that route with their patient versus someone like you who I'm imagining you have a limit on what you're going to do and you have that conversation with your patient of here's what you would recommend to have that natural, fresh, vibrant look.
One of the most important decisions in plastic surgery is the decision of restraint, or how to
Mm,
say no, how to
yeah.
properly direct a patient. And one of my favorite Shakespeare quotes is discretion is the better part of valor, where what we really need and what a patient is truly asking for is aesthetic judgment. When
Mm.
I say that the question is not what can we do, how many things that can we do, but really what are the best things that we can do, that's sort of tied into that question, where it's not difficult to pull a face very tightly, but what's difficult is to determine what is sufficient to improve the feeling of mid-face descent, a heavy nasolabial fold, jowling, neck laxity, but not so much that you go into the realm of a shiny, pulled, taut face, or a Joker mouth deformity where the smile looks slightly too large, or a
Yeah.
two-dimensionalizing of the face. So the best plastic surgery outcomes are very much medium. They're in the gray area where you are balancing two different extremes. And so the decision making about how to hit the perfect part of the gray area is sort of like hitting the center of a dartboard. It's not like, you know, knocking the dartboard down, which is sometimes how it feels.
Is it realistic to think that if a woman goes in and she has some work done on her face, whatever that is, and it's within this gray zone, so she has that natural youthful look or that fresh look. I actually don't like that word youthful because I'm 58 and I'm not going to look like my daughter who's 29.
Yeah,
But
nor should you have to. Yeah,
right,
I
right,
understand.
right. But does that mean that if that was me 10, 20 years down the road, I would have to go in and do something again to also achieve that gray zone optimal space?
Well, yes, and also no. When we think of a plastic surgical procedure like a facelift, for example, we are resetting the clock, but we're not stopping the clock from ticking. So
Hmm.
facial aging will continue to march forward. And the changes that we see at every level of the tissues are very much dependent on not only estrogen and progesterone levels, but how many years we are on this planet. So what we see in the mirror might be a heavy liner wrinkle, but what's really happening is changes at the level of the bone, muscle, fascia, fat, subcutaneous tissue, and skin. So each one of those layers of tissue might be changing 5%, 10% a year. And the global change is part of why we think of a global facial optimization. So,
Hmm.
if you were to do a procedure now, do you have to do it again? No, you don't have to do it again. You will always look better than had you not done the
Hmm.
procedure in the first place. But will you look exactly the same? No, you will still be subject to the same changes at the molecular and cellular level that dictate aging for all of us.
Very interesting. It makes a lot of sense. So I want to dive more into the face right now. That's your specialty because this is what most of my listeners are thinking about as they step into their second act. I focus a lot on women who are navigating post-menopause, and women are in this second act for 40% of their lives. And my work is about helping them see that chapter as an opening and not a closing. And part of that opening is how she feels when she looks in the mirror. Is she stronger, more connected to herself? Does she feel like herself? Her skin and her hair are high on that list. And when it comes to her face, what is the woman over 50 wanting most in plastic surgery or non-invasive procedures from your lens?
I would say there are three main things that I'm seeing. And obviously, every patient is different. Everyone is coming from a different background and also perspective. But change number one that people want to really think about keying in on is the quality of the skin. The
Mm,
juicy, lustrous feeling of a high collagen, high elastin skin where it feels smooth, it reflects light beautifully, and it has a certain, juiciness and healthiness of skin quality. So for skin quality, we can do many things ranging from topicals to PRP microinfusion to lasers and all of the above simultaneously. The second big concern that I hear from patients who are in this second act is the feeling of descent. So the
mm,
tissues tend to collapse forward. The midface and jowl tend to come inward and crowd the central facial features. The lateral eyebrows tend to hood down, and many people come in making sort of a big headband movement with their hands. Like, I just want to take it all back. So the idea of re-elevating or resuspending tissues that have descended is a very common concern. And we can think about that both non-surgically and surgically with injectables to structure the face, suture suspension to lift in a non-invasive way, and invasive surgical procedures like facelift and neck lift and blepharoplasty. And then the third big concern that I hear patients talk about in this era is volume loss.
mm.
And when we're 25 years old, the face is typically heart-shaped. We call this the inverted cone of youth. And that means that there's sort of a pleasant fullness to the upper third of the face and a narrowness down below. With time and aging and menopause and beyond, what we start to see is an inversion of the heart shape of the face. So the face becomes trapezoidal. We lose volume in the
Mm.
temples and tear troughs and nasolabial folds, marionette lines, and then we gain volume in the neck, the jowls, and the heaviness down below. And so part of my job here when someone complains about volume loss is replacing lost volume in the upper face, either with autologous fat grafting or with filler. And then another part of my role is to help change the shape of the face a little bit more back to how we remember it.
Hmm. That's where I want to start with your descent of tissue because it sounds like that's where the facelift and the mid facelift and the midi facelift and the neck lift all sort of live. And so if you could start with the most rigorous and technical of the facelifts that you perform and make your way down to the non-invasive options, take us through how you map out this order and where you see which one would go to which patient.
Got it. Great question
It's
and
it's a
very
big
broad. So
question.
I will try to I
Yeah,
will
give
try
us
to make
yeah,
it clear and
the
help
cliff
you
notes.
see it how I see it.
Uh-huh.
Okay. So the term facelift, first of all, is used very colloquially to mean many different things. But first and foremost, it's important to understand what is your actual question. So facelift as a generic zeitgeist term can be used to indicate temporal or coronal brow lift, which means when the eyebrows are hanging down. Upper lid blepharoplasty for hooding of the upper lids. Lower lid blepharoplasty for puffiness and bags under the eyes. Mid-face lift, which is descent of the malar fat pad or apple of the cheek, and heaviness of the nasolabial fold. Lower facelift, which is the lower border of the face, and here you see jowling, an indistinct border of the jawline, marionette lines, and heaviness in the lower face. And then finally, neck lift, which really refers to submental fullness or puffiness or fat under the chin, stringy muscles, which are called platysmal bands, and excess skin, like kind of loose, extra drapey skin. So the first most important thing to do is to diagnose what is the concern with the specific person and what is our approach. I'm going to, for ease, focus just on the face and neck, and we can get into everything else later.
Okay.
But the idea of a face and neck lift, the state of the art is to lift the deep tissues of the face and neck in a multi-vectored way, meaning not pulled all in one direction, but replaced to where they go. And so this is sometimes referred to as lifting the SMAS, which is the deep muscular substructure of the face. And for mid-facelift, we lift it vertically, for lower facelift in a transverse direction, and for the neck, the platysma is lifted horizontally. There are many terms associated with facelift surgery, including deep plane facelift, SMASectomy, SMAS plication.
Also, what about vertical restore? Is that
And
one too?
vertical restore is a vertical elevation of the SMAS muscle. That's a SMAS plication.
Okay.
So the concept of how these are differentiated is the level of depth that you go. Remember, I talked about how the tissues are layered: the bone, muscle, fascia, fat, subcutaneous tissue, skin. We know that a skin-only facelift is really not sufficient. It drops quickly and it's not enough to support the tissues. Getting at the deep plane, whether it is in the SMAS fascia, the SMAS itself, or below the SMAS, has different advantages and disadvantages for different patients. A skilled surgeon must be able to be nimble and perform the correct operation for the correct patient. So not every single patient requires a SMAS plication or SMASectomy or deep plane facelift or any of the above. But every patient requires that you lift the deep structures of the face and that you treat them in different vectors, like vertically, transverse, and horizontally, depending on the aging pattern. So I would say the state-of-the-art most invasive procedure is referred to as a deep, substructural, and multi-vectored facelift. And there are many terms thrown around. I apologize on behalf of all plastic surgeons that we have made this field very confusing for the audience, because there are people who throw around proprietary terms or who coin a phrase, and it makes it a little bit more confusing. But at a technical textbook level, that is a facelift.
And that's what I was thinking as you were talking about all of this, how confusing it is because of the different names that are given to this procedure. That as a woman walking into the office, if I really don't know all of these things inside and out, which how many women do, how do you know you're getting the best advice? Are there any red flags we should look for? Is there a question we should ask?
I think it's mandatory, first of all, to see a plastic and reconstructive surgeon who's board certified by the American Board of Plastic Surgery. There
Mhm.
are many routes to being someone who performs facelifts, and many of the loudest voices on the internet are actually not board certified plastic surgeons. So you
Hmm.
have to be very careful to check this basic credential. It's very easy to check on the ABPS, American Board of Plastic Surgery website. So that is a straightforward, low-hanging fruit. If
Okay.
someone is board certified, it means that they have committed at least a decade of their life to the in-depth anatomy, training, and safety practices involved in acceptable and safe surgery. They've also passed ethical screenings. They take yearly certification exams. They have a body of their peers that says that they're legitimate. So I think this is
Okay.
a bare minimum, and many patients, maybe half of patients, don't follow this bare minimum. So please follow the bare minimum of making sure it's a board certified plastic surgeon, not a cosmetic surgeon, and not a different board, because there are a lot of things that sound similar.
Very
Second,
good to know.
second, having a plastic surgeon perform a facelift or any procedure for you is sort of like commissioning an artist to make a very beautiful and very high stakes painting for you. So you have to like what they do. You have to like the style. Are you a Monet person or a Picasso person or a Leonardo person? So you need to review imagery and see what you gravitate toward. There is no right and wrong in aesthetics when it comes to personal sensibilities, but we all know what we like and what we gravitate toward. So there are people who have more exaggerated and dramatic results. There are people who like a lot of volume and put a lot of fat in faces. There are people who have a more understated and natural result. So you should go in having an understanding of the vibe of your surgeon. The third thing is you have to be able to collaborate with your surgeon. So you cannot have a relationship where you can't give and receive feedback and ask and answer questions. You have to be able to work together with someone so that they can be on the same page. And then fourth, I would like people to try to find surgeons who take seriously each individual case. And this might sound obvious, but one of the biggest days in your life is just a regular day in my life. And so it takes discipline on the part
Mm,
of the surgeon to really focus on each person and not just show up at work and walk into the operating room. So for
it's such a good
me,
point.
yeah, and it's very hard to explain this to someone who doesn't have a career in surgery.
Yep.
But this is just the reality of how the job works. And so for me, I spend at least an hour preparing before I even do the surgery. I'll draw out, actually, I was doing some of my drawings just now. So I'll draw out maps of the anatomy of my patients that I'm planning. And I will study their anatomic features and characteristics. I'll study my notes about them, and I will make sure that I am making a blueprint for myself of each patient. And it's an exercise that focuses me and makes me stay on task. Second, I'm going to review youthful photos of the patient. And that helps me to maintain identity even when we're doing an invasive surgery. We've all seen examples of celebrities who had technically acceptable surgeries and just don't look like themselves anymore. And that is a failure of the gray area. It's not a failure of the stitch or the excision, it's just the judgment involved. And so by studying photos from a patient when they're in their 20s, 30s, 40s, 50s, I can really understand, okay, they've always had a heavy lidded eye, or they have a special characteristic smile, and this dimple has been there from the beginning. What do we keep and what do we let go of? And then third, I talk a lot to my patients. I typically will have one or two follow-up phone calls, FaceTimes, or visits to really get into the details. And so I think that those things are very important in the patient experience. It is much less about going into your surgeon and saying, give me a ponytail, vertical restore, deep plane, mini incision, smazectomy, smaz we don't expect patients to be able to say that. And when they do, it often doesn't mean anything. The diagnosis is part of the domain of the plastic surgeon. Like when you hire a handyman, they're not going to make you choose the subfloor. They're going to just tell you, like, you need a foundation and then you need the
Right.
floor. We sort of lack the framework if we don't have expertise in something to comment on it.
I really love how you look at pictures of your patients. I've been to some plastic surgeons and they've never once asked me to bring in a picture of myself. I've been talking about doing certain things. I had my nose done actually when I was 16. And, um, you know, back then, maybe it was different because that was, I'm 58 now, it was a long time ago, but he never really asked me a question about how I saw myself or my feelings about getting it done. I had a little bump on my nose that I wanted taken off, but he did have a very distinct style of all the noses kind of looked the same. And now looking back on it and hearing you say this, you have to really understand um, your surgeon's style. That really makes a lot of sense to me.
Yeah, there are for a nose in particular, there are so many ways that that surgery can be done. A conversation I have with so many patients regarding rhinoplasty is, about their ethnicity, their heritage, their family
Mhm.
relationships. Sometimes people want to look just like their slightly better looking cousin, but still feel like
Right,
themselves. Then other
right.
times people want a totally different nose. And so much is possible with the nose or really with any part of the face that it's important to be on the same page. There are probably more than 10 to 20,000 tiny decisions that are made in your surgery while you're sleeping. So you
Mm,
have to really trust that the person who's making those decisions and who is on the other end of the scalpel is making excellent decisions on your behalf. You really have to feel that they're in your head and they know which way to zig and which way to zag when there are all those little decisions.
100%. You do something very special with rhinoplasty that's non-invasive. Can you talk about that procedure?
Yes. This is an amazing technique called non-surgical rhinoplasty. And non-surgical rhinoplasty was really born out of two things. First of all, my love of deep facial anatomy. and invasive surgery, including rhinoplasty. And second of all, me coming of age at the exact right time in the world when the most modern generation of hyaluronic acid-based fillers came to the market in the early 2010 era. And the concept of non-surgical rhinoplasty is that I'm using micro droplet hyaluronic acid-based filler as if it were a surgical cartilage graft. In much the same way I use your own septal or ear cartilage in a rhinoplasty to create straightness, tip refinement, tip lift, and contouring. And non-surgical rhinoplasty is amazing because there's no downtime. It's sort of like Botox. It takes a minute, literally. You leave looking normal. You can go back to work. And although the result is not permanent, we can get outcomes that look nearly like surgery, or in some cases, they're more precise than surgery. Most patients need to maintain a non-surgical rhinoplasty at 6 to 12 months, and it does gradually diminish over time, almost like your hair color growing out or a glass of water evaporating. So maintenance is part of the trade-off here, but for the right patient and the right circumstance, it's a very amazing option.
I also think it's a great option because what if they aren't sure they want to have their nose done surgically? This is such a great entry level place to give it a try, right? Test it out to see if you like
Absolutely.
it,
You can
right?
try on the result before making a
Absolutely. It's
permanent
so
commitment.
cool.
The same idea, many times the nose and chin are thought of together because they are important cousins in the concept of the facial profile. And so
Yeah.
we can also create the feeling of a chin implant with a non-invasive technique. And a person can live with that and then graduate to surgery or decide that they want something different.
It's so incredible. I absolutely love that. You popularized the concept of suture suspension lifting. So I'm kind of circling back to the facelift, and I'm thinking that outside of surgery, all of the deep plane facelifts you were talking about, this would be down a notch and not be that invasive, but
Yeah.
still you might get results.
If somebody is not ready for an invasive surgical procedure, they don't want it, they don't have the downtime, there's a medical contraindication, it's more expense or time off of work than they're comfortable with, they don't want anesthesia. There's so many reasons why people may put on hold a surgery. We have non-invasive options, and the non-invasive options are in the realm of injections. So I would say structural contouring filler for the cheekbone, jawline, and chin to create a structural support buttress of the face is one option. And then another adjunctive option that gives you more lift than fillers, but not as much as a facelift, is suture suspension. And we've all heard of thread lifts and all
Yeah.
the horror stories about thread lifts. Suture
Hmm.
suspensions are not the same thing as thread lifts. They are a similar concept in the sense that we are using a surgical suture with perpendicularly oriented rasps on it to gain purchase in the tissue, to lift the tissues in different vectors. However, thread lifting is done superficially, right under the skin, and that makes it prone to rippling, extrusion, pulling, asymmetry, and a variety of complications. Suture suspension is done in the deep SMAS plane of the face. So we are avoiding all of those indignities of the prior generation of thread lifting. Now, suture suspension is not a permanent technique. It's not going to be your best option if you have profound skin laxity because we're not removing anything. But I would say suture suspension is almost like if you're wearing a shirt with no bra and then you put on a bra. It's lifting the deep structures. The shirt is the same. We're not
Hmm.
tailoring the shirt. If you want to tailor the shirt, you have to have a surgery. But we're not
Hmm.
tailoring the shirt, but in a semi-permanent, 6 to 12 month time frame, we can get a
Hmm.
lift of the deeper structures of the mid face, the jowl, the brow, and the neck. Those are the four areas that I prefer to perform. And that can be a great option that looks amazing in the right patient.
And if that patient, again, wants to graduate to surgery down the road, that's not going to interfere because I always heard the threading from plastic surgeons saying that it interferes with surgery down the road.
Exactly. Suture suspension uses dissolvable sutures made out of
Mhm.
polydioxanone that disintegrate over the course of a year. And as they go away, they're replaced by the body's own collagen. So it's almost like lattice in a garden with ivy growing into it. And then after a year, it's all ivy and no more lattice.
Mhm.
So suture suspension is not going to be a permanent object in your face. And second of all, it's not going to burn any bridges for future surgery. And this is something that I always think about because I intentionally have split my practice into surgical and non-surgical
Mhm.
because I think that that allows me to give the most customized and bespoke answers to my patients.
Mhm.
You know, if all you have is a hammer, then everything you see is a nail. If I only do
Mhm.
surgeries, there is a little inherent bias for someone who can only do surgeries to only offer surgery. And there's
Yeah.
a little inherent bias if someone can only do injections to only offer injections. And so
Mhm.
I truly try to ground myself and never feel biased so that I can give people very specific bespoke recommendations.
Absolutely. I want to move to upper and lower blephs, and especially the lower bleph, because so many women are feeling like they're waking up and looking really tired. First of all, most women are not sleeping that well. And so they think that their bagginess under their eye or the puffiness, the darkness, the dark circles, it's just that tired looking feeling around our eyes is a result of not sleeping or aging. And we gravitate towards serums and lotions and potions that are supposed to, and patches that are supposed to take all of that away. And I would like to hear from you what you think about all of these remedies out there on the internet to help the woman look like she has refreshed eyes. Do they work or don't they work? And is surgery really the answer for that specific person?
What an amazing question. So many of us have the feeling of tiredness under the eyes all across the age spectrum. When you're feeling like your under eye area doesn't look the way you want it to, it's typically because of one or multiple of the following three factors. First, periorbital hollowing. This means volume loss or emptiness or a dark circle feeling. And people who have this sort of sometimes feel like they look like a skeleton and there's a lot of darkness and a shadow. So the dark circle look. So this is the loss of helpful, beautiful fat in this area. The second thing you might be seeing is puffiness. These are people who feel like they always have puffy bags under the eyes, that when they eat salty food or don't sleep well or drink alcohol, it's extra puffy, and they're always wishing they could subtract something. So puffiness corresponds to herniation of your own fat pads in the under eye area. And then the third concern that we typically see with the eyes is excess skin. So some of us have a lot of bunching of the skin underneath the lower eyelash margin, and this can make the skin feel wrinkly and puckered and crepey. So the correct solution depends on whether you're seeing one of these things, some of them, or all of them. I'll start by saying that something is better than nothing. So a topical based product is better than not doing anything at all because at the very least, you're hydrating the tissue around the eyes. Particularly peptide-based products can help to improve turgor or the juiciness and thickness of the eye skin. So it's not false, but no cream is as good as an injectable, and no injectable is as good as a surgery. So
Mhm.
if you're in the realm where you really don't want to do anything and you never want to know me or anyone like me, then a peptide eye cream is great. I, for one, love my polypeptide eye cream from my own line, which has been formulated with multiple plant-based phytopeptides to improve that feeling of brightness around the eyes. If you are ready for something a little bit more invasive, we can think about Botox for crow's feet, tear trough augmentation to replace lost volume, or even the concept of autologous fat grafting to replace lost volume. So that's a little bit more invasive. You need to go into a plastic surgeon's office and have a credible person with some aesthetic sensibilities and anatomy skill take care of you. And then finally, the last rung on the ladder is lower blepharoplasty. And depending on the patient, sometimes a bleph will include removing or reducing the fat pads. Sometimes it will include removing or reducing excess skin with a skin pinch. And sometimes it will include fat grafting for periorbital hollowing. The combination of which approach is right for you depends completely on your unique anatomy. And so it's very important, sort of like our discussion before, to first analyze the problem and then figure out the solution.
Is genetics playing a role here as well?
Huge. Genetics is probably one of the most important things that play a role. I would say between genetics and UV exposure and smoking, that's probably 80% of the aging around your eyes.
Yeah, yeah. I want to talk a little bit about more non-invasive procedures that you do, because besides being a board certified plastic surgeon, you also do injectables, you also had mentioned your skincare line. So you have this very vertical pillar of help and solutions to bring to your patient population, which is so cool because I'm all about precision medicine. And this is just part of precision medicine where someone can come to you and you have all of these different options to offer her. You aren't just a one-stop for plastic surgery. And that's probably been a huge draw for your patients.
Yeah, I mean, I feel very blessed to be able to do something that I love and to also be able to give my patients extremely customized and specific
Yeah.
solutions. When we're thinking about all the changes of facial aging and all the tissue layers being affected, it's my job as a true expert in facial anatomy to be able to address all of those different layers. And that involves excision of skin, topical skincare, volume replacement, fat, myomodulation with neuromodulators, surgical excision. It involves the works. And so that's part of why I have my practice the way it is.
Yeah. Is it ever too late for a woman with very mature skin? I'm talking someone in her 70s or 80s to start anything new to help, not obviously reverse the clock, but to help her get a nicer result of how she wants to look.
It's not ever too late. I would think about these changes in different stages depending on who you are. But if you're a very mature person with signs of significant wear and tear on the skin, you do have to manage your expectations. But it may not be one treatment of a laser that will return you to your 40-year-old self. And I
Mhm.
would say it's probably definitely not going to be. But each time we think of an intervention, it's sort of like one pass of an iron. So, with progressive improvement over time, you can absolutely improve the quality of somebody's skin.
So, circling back to non-invasives, the woman who is getting a deep plane facelift or a mid facelift or a mini lift, are you also developing a plan of these non-invasive options for her? Is it just the facelift and you're good to go for the next 10, 20 years? Or is it a comprehensive approach of mixing different things, injectables and biostimulators?
It's absolutely a comprehensive approach. I think one of the biggest misunderstandings is that the choice between surgery and non-surgical procedures is dichotomous, that you choose one and not the other.
Hmm.
When the reality is the best facelift results are maintained over time. You continue to have your platysma, frontalis, corrugator, procerus, orbicularis. You have all the muscles still in your face. And so you still, if you like the idea of being smooth, you still need to maintain Botox. Even if you have a totally perfect facelift, over the course of each year, you will get recurrent progressive volume loss because that's just the picture of how facial aging works. And so judicious injectables to replace lost volume continue to be necessary. And it's sort of like, getting your car fully serviced and then still needing to change the oil and fill the gas tank, and there's still a little bit of daily maintenance needed, but we are resetting the overall starting point and the ending point.
Yeah, it makes total sense. So I know we only have a few minutes left, and I want to talk a little bit about skincare for women because this is something I have focused on before, but I want to hear from you because you know skin deep what is going on. What are your thoughts on estriol cream for use on a woman's face? There is a huge push out there for women to replace this lost estrogen topically on their skin. And there's other people who are saying there's not enough science out there. What are your thoughts on that? And what are other things women can use that are going to be helping with that renew and repair for their skin?
If you are using estrogen and hormone replacement therapy, it's important that you have one provider who is managing all of your hormones. So I want to start by saying that because we've seen the cropping up of
Yeah.
many direct-to-consumer startups where people are buying estrogen cream here and pills there and a patch here. So one thing that you can do for your health that's great is to centralize it so you only talk to one person about your hormones, so your total body estrogen and progesterone load can be optimally maintained.
I feel like giving you a high five right now.
Yes, thank you. High five. Yeah, so that is the first and most important thing. And it should be somebody who's good.
Yeah.
Your OB-GYN, your endocrinologist, your internist, somebody who has broad-based knowledge in women's health and these topics. For most women who are contemplating hormone replacement therapy, standards are changing, and so many women are starting this before they're even in menopause, when they're perimenopausal in their 40s. And so the classic standard approach for most women is a low dose estrogen patch, and if you have a uterus, a low dose oral progesterone pill. This is not medical advice, and you have to talk to your doctor
Mhm.
because not everybody is a candidate for this. Many people who are also using hormone replacement therapy will be prescribed a vaginal estrogen cream that can help with replenishment of the flora and lining of that area. It's very helpful to use a tiny amount of estrogen cream or estriol cream on the thin tissues of the face, the periorbita, the neck, and even a little bit on the back of the hands. However, it's not a complete free lunch because that can, while it does help your skin quality overall, it can slightly increase risk of hyperpigmentation and melasma, particularly in people who've been wrestling with that for a long time or
Mhm.
people who have medium to dark skin tones. So it's all a balancing act. What I suggest for most of my patients is a pea-sized amount of estrogen cream mixed with my resveratrol niacinamide rich cream, or it really can be any facial cream that's really good that you like. So mix it a pea and a pea size. So it's halved, but has a better, smoother consistency. And you can apply that to the face, periorbita, neck, and dorsum of the hands once or twice a week.
Mm.
The
Okay.
early data on estrogen topically is excellent because it does not give you the same risk profile of coagulopathy and other problems that oral estrogen or oral medication does. And it does show promising evidence to remodel the skin. I would say this is not something that is currently focused on by the gynecological community, in part because it doesn't really matter, right? Like nothing that we're talking about is going to save your life. It's my profession is not about quantity of life, it's about quality of life. So this is
Mhm.
certainly secondary to anything that is more medically needed. But I think that that can be a great idea. And then on to your other question, what should you be thinking about for your skin? One of the biggest skin problems in patients over 50 is the aggressiveness that people treat their skin with. And so as the dermis thins, we need to typically think about maintaining barrier protection, maintaining hydration, and giving it more suppleness. So sometimes mature patients need to slightly cut back their retinol usage to a slightly lower strength or every other day. Sometimes people can benefit from topical estrogen cream. I also think there's an amazing role for a mixed molecular weight hyaluronic acid serum. So I like my hyaluronic niacin serum. And soothing ingredients like peptides, along with active ingredients like vitamin C. So the super, super basic would be a retinol, a mixed molecular weight hyaluronic, and a vitamin C serum. And then think about hydration and replenishment. Maybe you're also thinking about a little bit of topical estrogen here and there, and then SPF. So we kind of want to give the tissue what it needs, nourish it and not overstrip it, and then protect it.
Yes, that is all such great advice, especially with the inundated information we were getting on so many products, especially these new creams that are marketing to people who are using GLP-1s. I don't know if you've seen any of these, but they are literally called GLP-1 like face cream, right? It's just ridiculous. My last question to you is red light therapy masks for the face, yay or nay?
There is data that suggests that red light therapy works, but for at-home level masks, you have to wear them for hours and hours and hours and hours to reach the energy threshold that is shown in some of these studies. So, to me, I don't think it's very practical for most people to wear a red light mask for more than half an hour or an hour. Certainly not for 8 to 10 hours to get this study level improvement in skin quality. So for me personally, I pass on it. I don't think a red light therapy mask is harmful to you. So if it makes you happy, that's fine too.
You know what? We're limited on funds. We all have a beauty fund. And so if that's going to be out and we need to focus on other things to achieve our goals, I agree with you.
Yeah, given allocation of precious resources, I would say you're better off saving on the red light mask and thinking about even once a year or every 18 months, a more clinical in-office resurfacing.
That's a great idea. Well, Dr. Devgan, thank you so much for your generous time, your expertise, your wisdom. I know this is going to help a lot of women be able to make decisions and really contemplate what they want to do moving into the future of their second act.
Amazing. Well, it's such a great time of life and an amazing topic, and I'm so honored to get to speak with you and your audience.
Oh, well, thank you so much. And where can we find you?
You can find me at laradevganmd.com, at Lara Devgan MD on Instagram and TikTok. And my skincare line is drlaradevgan.com.
And I love your Instagram account. I really love how you explain things. You show before and after pictures. I mean, a lot of people do that, but yours are just so incredibly beautiful. And I can see why you are a very well sought out board certified plastic surgeon.
Thank you so much. And that, I would say that's my main channel of communication. So Instagram at Lara Devgan MD. And I am so happy to get to speak with you about this.
Thank you so much. And thank you all for tuning in. Until next time.
Okay, thank you.
Thank you for spending this time with me today. If something in this episode made you think, good, now do something with it. That's what Afterpause is built for. If you are enjoying the podcast, please subscribe, leave a review, and share it with a woman in your life who is ready to stop piecing it together and start moving forward. And if you've seen multiple doctors, spent thousands of dollars, and are still walking away without a real plan and feeling confused and frustrated, I hear you. And I built something specifically for you. You have told me you want answers and direction on your menopause journey without a huge commitment. No 8-week program, no online course, just one focused hour with someone who knows the menopause space inside and out, has spent years building a national network of vetted clinicians, and will help give you a clear, direct path forward. No fluff, no filler, just exactly what to do next, finally. And that's my Menopause Care Consult. One time, 1 hour, and women leave with a real plan for the first time. You'll find the link in the show notes. A quick and important note before you go. By listening to this podcast, you agree not to use anything you hear as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Always consult your own physician for any medical issues you may be having. This applies to everything I share and to every guest who joins me on this show. That said, stay curious, stay strong, and keep showing up for yourself. This is your time. I'll see you next week.